Good evening, Rachna ma'am.
Good evening.
Bala sir, shall we start?
Yes, you are good to start.
Okay, sir. So,
Can I start?
yes, sir. Yes, sir. We'll start. Good evening, everyone, and a very warm welcome to all our distinguished faculty members and participants joining us from across the country. On behalf of the International Association for Integrated Oncology, IAIO, it's my pleasure to welcome you all to today's session of IAIO Expert Insight Lung Cancer. IAIO is a professional platform focused on advancing oncology education and collaboration among healthcare professionals. We are truly privileged to have an eminent panel of experts with us today, and I would like to take a moment to introduce our distinguished program director. It gives me immense pleasure to introduce our program director for today's session, Dr. Vala Stalin Chaudhary. Dr. Vala Stalin Chaudhary is the Chief Medical Oncologist, Hemato-oncologist, and BMD physician at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam, Andhra Pradesh. He has extensive expertise in medical and hemato-oncology, including lung cancer management and modern systemic therapies. A very warm welcome to you, sir. We are honored to have you with us today. To deliver the welcome address and introduction, over to you, sir.
Yeah, thank you. Good evening, everyone. It gives me great pleasure to welcome you all to this IAIO Expert Insight meeting on lung cancer. So we all know that the lung cancer treatment has changed remarkably over the past few years, and we have moved from predominantly chemotherapy based to a precision oncology and immunotherapy based approach where molecular profiling and biomarkers increasingly determine how we treat each individual patient. Therefore, the today's program has therefore been designed around some of the most relevant and rapidly evolving areas in lung cancer. So we'll begin with the current standards in driver mutated NSCLC, focusing on how we can optimize the first line targeted therapy. We'll then look beyond our present standards towards the next generation TKAs, antibody drug conjugates, bispecific antibodies, and other emerging targeted therapies. And the third session will be based on the small cell lung cancer, where after many years of relatively limited progress, immunotherapy and newer DLL3 targeted approaches are beginning to change the treatment landscape. And finally, we end up with a panel discussion on choosing the best immunotherapy strategy in advanced NSCLC, who should receive it, when, and which I am sure will generate a very practical discussion. So we have an excellent group of faculty and panelists. So I thank all the faculty and panelists who have agreed to be part of this meeting and enlightening the audience regarding the recent advances in the management of lung cancer who joined us from across the country. And I sincerely thank all of them for taking the time to be with us this evening. And I also thank IAIO for organizing this academic initiative and all the delegates who have joined us. So without much of waste of time, we'll move on to the academic program. So there was a slight change in the speaker alignment of the program. So we first start with the small cell lung cancer. So because Dr. Rajni will be delivering the her lecture a bit late. So we'll start with the small cell lung cancer by Dr. Rachna, followed by Rajni's talk and followed by Dr. Venkatesh talk. So I would like to invite Dr. Rachna to deliver her talk on the small cell lung cancer in 2026 from chemoimmunotherapy to DLL targeted therapies. Over to you, Rachna.
Good evening, sir. So I would be dealing about the small cell lung cancer. I would like to share my screen. I hope my screen is visible in the
Yes,
Yes,
sir.
yes.
in the full.
Visible and you are audible.
Okay, sir. Yeah. So as Stalin sir was saying about the lung cancer, that so many changes which are happening. We all know that small cell lung cancer was one part of lung cancer which did not see much changes except for the recent developments which are coming across in the few years only. Whereas non-small cell lung cancer, we had so many drivers to target to act with immunotherapy. Even immunotherapy trials were initially in the non-small cell setting, which have got major approvals and all. Then only came their approvals in the small cell lung cancer. So I'd like to discuss about the targeted therapies which are now available for us in small cell lung cancer. About 5 to 6 years back, or even prior to that, it was only chemotherapy which was helping us out. And we all know how bad the small cell lung cancer prognosis is. But yes, there is a shift in the prognosis and survivals of small cell lung cancer with the chemoimmunotherapy combinations and also with the newer targeted therapies. So this is what has shifted in 2026. We have established the chemo IO as the baseline standard of care. It was only chemo prior, but now chemo IO is the baseline standard of care, elevating the long-term survival through broad immune checkpoint inhibition. And now we are also able to define different molecular vulnerabilities in the small cell lung cancer also. Like in NSCLC, where we have different driver mutations, even small cell, we are able to define the various molecular subtypes in small cell lung cancer so that we know which subgroup might benefit with the different type of therapies. And another one is using the antibody drug conjugates so that we are able to deliver the targeted payloads directly to the immune cell, protecting the normal cells and giving a better efficacy over the chemotherapy alone. So this has led to the development of bispecific T cell engagers and antibody drug conjugates, which are also paving their way into the small cell lung cancer setting with improving the survivals and also trying to minimize the toxicities and prolonging the overall survival. So for small cell lung cancer, you don't see a steep curve in the therapeutic landscape which was happening. If you see the other tumors, there is at least a slight curve which is going on improving over a decade or more. But for lung cancer, the small cell lung cancer, for over 30 years, till 2018 from the 1970s, it was a plateau in the development of therapies in both the localized and also the advanced SCLC. So initially it was surgery with non-platinum chemotherapy, then moving on developed into a platinum doublet chemotherapy which came in 1980s along with radiation which was being given for the primary side. So from 1980 to 2018, it was the same thing which we were all following, platinum doublet chemotherapy. Then in 90s, we came to know about the concept of prophylactic cranial irradiation for patients who have responded to CCRT or who have responded to your chemotherapy. So this was what the standard of care till 2018 when we got the immunotherapy combination with chemotherapy from the IMpower 133 data in the first line extensive stage small cell lung cancer. So from here onwards, there is an improvement in the targeted therapies which we are getting. We have the Caspian trial of durvalumab plus chemotherapy again in the first line extensive stage small cell lung cancer, and you have the lurbinectedin in the second line extensive stage. Maintenance lurbinectedin IAM forte in the 2024 we got that, and also we have a development in the limited stage small cell lung cancer, that is the consolidation of durvalumab from the Adriatic trial which has shown improvement in the limited stage SCLCs also. So this is one improvement in the limited stage SCLC other than the CCRT and the prophylactic cranial irradiation which we consider giving. So we have the consolidation durvalumab in the limited stage, which is also approved for use. Then came the BiTEs, that is recently, just a year ago, we have tarlatamab in the second line setting for the extensive stage lung cancer from the Delphi 304. And now from 2026 and beyond, we are going to get some data for the tarlatamab in the first line. We have other bispecific and trispecific studies ongoing. Antibody drug conjugates are being analyzed, and radiopharmaceuticals are also being studied in the small cell lung cancer setting. So within 2 years, we had so much expansion in the precision-based therapy from the Adriatic trial, the tarlatamab, and the novel therapies, which are targeting specific subtypes in the small cell lung cancer. So the Adriatic, this is a single slide on the limited stage SCLC. This is the Adriatic breakthrough which we have got with the durvalumab consolidation. We have seen durvalumab consolidation in NSCLC from the Pacific data. Similarly, they have tried durvalumab consolidation in the limited stage small cell lung cancer. And yes, here also it worked well, improving the median overall survival by around 20 months. So you see the median overall survival for durva consolidation is 55.9 months compared to 33 months in the standard concurrent chemoradiotherapy arm with a hazard ratio of 0.73. And another development is in the prophylactic cranial irradiation. Now previously we were giving a patient for the limited stage or extensive stage responding to treatment. They were considered to be given only prophylactic cranial irradiation. But we do have some data to say that we can avoid prophylactic cranial irradiation if given that the patient is willing for the MRI surveillance. So this is increasingly replacing the routine prophylactic cranial irradiation in patients with reliable neuroimaging access. This helps in preserving the cognition without compromising on the survival. So yes, it is not mandatory to give prophylactic cranial irradiation for all your SALC patients. You do have an option of MRI surveillance for a patient who is going to be compliant with the surveillance and who has access to the MRI imaging also. So these two things in the limited stage SCLC. Then moving on to the molecular subtypes in the SCLC, now it is being shown that it is not a single disease. We have SCLC A, P, N, and I. SCLC A is the ASCL1 driven mutation, which is dominant neuroendocrine subtype, and this has a higher DLL3 expression and also platinum sensitive subtype. Whereas the SCLC-P is the POU2F3 driven subtype, which is non-neuroendocrine subtype, high REST expression, and it is vulnerable to the PARP inhibitors and the IGF-1 receptor inhibitors. So this is a complete different subtype from the SCLC-A. This is a non-neuroendocrine, sensitive to the PARP inhibitors. Then we have the SCLC-N, which is a neurod1 driven. This is again a neuroendocrine, but a MYC amplification, and it is found to be more vulnerable to the Aurora kinase inhibitors. And the other one is the inflamed variety, which is again non-neuroendocrine, immune inflamed, high T cell expression. So preferentially, it is going to benefit from the immune checkpoint inhibitors. So SCLC-A benefiting from the DLL3 expression and a platinum sensitive tumor. SCLC-P, which is vulnerable to PARP inhibition. SCLC-N, neurod1 driven, which is sensitive to Aurora kinase inhibitors. And SCLC-I, the immune inflamed, which is sensitive to your immune checkpoint inhibitors. So yes, future is going to most probably decide on which molecular subtype the patient is in of this SCLC, so that you can plan more precision-based oncology for the SCLC patients also, especially in the extensive stage disease. So why are all these things important? Because why are the subtypes are important? It is not just to know the treatment, but there is something called as the lineage plasticity, where the platinum sensitive SCLC cells, when they are exposed to your platinum agents, the cisplatin or chemotherapy exposed cells, they have a chance to change the subtypes into an SCLC-N or a SCLC-I phenotype, that is the immune inflamed or the platinum resistant SCLC-N phenotype. So this implies that your cell, which was initially platinum sensitive, might become a platinum resistant in view of the therapeutic pressure which they are being exposed to. So the phenotyping switching creates a stem cell-like plasticity, rendering them static, uniform chemotherapy ineffective over time. So even if you give second line and third line therapies, the responses or the outcomes would be very dismal for these patients whose lineage is being switched from the sensitive phenotype to the resistant phenotype. So for the extensive stage small cell cancers, the frontline chemo IO baseline, what the drugs which we have, what data which we have. all show that there is an improvement with your immunotherapy and chemotherapy combination, but still the overall survivor is again clustering around 12 to 15 months only. So they are not giving you a dramatic improvement like how we see in NSCLC, where the survivors with your targeted therapies are way beyond 5 years. But for SCLC, with the combination of IO plus chemotherapy, the overall survivor is plateauing around 12 to 15 months. If you see the rational trial where treslelizumab was combined with chemotherapy, the median overall survival was around 15.5 months. Severe adverse events seen in around 86% of the patient. Caspian trial, where durvalumab was combined with chemotherapy, again median overall survival around 12 months only, 65% with severe adverse events. IMpower 133, atezolizumab plus chemotherapy, median overall survival 12.3 months again, with 58% of severe adverse events. Astrum 005, the serplulimab plus platinum combination, you have a median overall survival of 15.4 months, a slightly lesser adverse events of around 33%. And adapirimab, that is capstone one, which again gives you a median overall survival of around 15.3 months. So if you see it is 12 to 15 months only, that is 1 year to 1 year 3 months, with all the IO plus platinum based combinations in the frontline extensive stage small cell lung cancer. So why is the immunotherapy benefit so modest in SCLC? It could be one reason which we have seen the subtypes. So everyone is not an immune driven subtype. And also we know the PD-L1 expression in SCLC is very less. Though the selection of chemo-immuno combination is not based on the PD-L1 percentage, there is a low PD-L1 expression in SCLC tumors compared to the NSCLC subtype of tumors. And also there is a diminished antigen presentation machinery because of the reduced MHC class 1. This impairs the CD8 plus T cell recognition by the tumor cells. Another problem is with the immune suppressive tumor microenvironment, which have inadequate CD8 positive cells, and VEGF overexpression, which suppresses the ICAM and VCAM, that also inhibits the immune activation. And another problem is with the DLL3 driven suppression. The high DLL3 expression correlates with suppressed immune related pathways. So all these factors combined together are making the benefit with immunotherapy and chemotherapy combination modest in extensive stage small cell lung cancer. So how can we overcome this minimal benefit which we are seeing with the chemo-IO combination? How can we overcome this plateau? So there are different strategies which can be used in the front line if you have used chemo-IO baseline. The other strategies which we can do is we can add an VEGF inhibitor so that will increase the CD8 plus T cell infiltration which was lacking in the small cell lung cancer setting. Another combination is using thoracic radiotherapy to induce immunogenic cell death and prevent intrathoracic recurrences. This is after chemotherapy, not for the limited stage, the extensive stage. If you give thoracic radiotherapy, this can induce the immunogenic cell death and prevent intrathoracic recurrences. Another one is your maintenance intensification. So once you're done with your frontline chemotherapy and continuing your immunotherapy, you can add a second agent or a third agent to this maintenance so that you can intensify it and maintain the remission which you have attained. And also it can have an active myeloprotection to extend the progression-free survivals. So the first strategy, the angiogenesis immune synergy. In this we have the ETER 701 trial where they have combined the anlotinib, benmelosobrat and platinum plus etoposide combination, which has resulted in improvement in the median overall survival of 19.3 months. So we have seen that 15 months was what maximum we could get with chemo-IO combination. But in this trial with the 4-drug combination with the VEGF inhibition, the median overall survival is around 19.3 months. But the problem was 93% of the patients experienced grade more than 3 adverse events. So this was the main problem with this 4-drug combination. And we also have the bispecific alternatives which are being tried, which target both the PD-1 and VEGF inhibitors. And phase 2 signals have shown that around 80% overall response rates when you are using a bispecific drug which has both VEGF and PD-1 inhibition. So, and for the central tumors which are known to be very hemorrhagic, which have high chances of hemoptysis risk, there is one option of giving an induction strategy where we give only 2 cycles of purely cytotoxic chemotherapy, chemo plus IO combination. Post-induction, you can add your VEGF inhibitor. So you know that the central tumors are more hemorrhagic. So you can't give VEGF inhibition upfront for these patients. So you can just give chemo-IO for 2 cycles, reduce the size, reduce the chances of hemoptysis, and then you can add your VEGF inhibitor. This has seen in the camrelizumab plus apatinib trial, which was after induction. It yielded a 97% disease control rate and a median overall survival again improved to 17.3 months. So for central tumors, if you want to give VEGF inhibition, this is one strategy where you can give chemo IO for 2 cycles followed by VEGF inhibitors like camrelizumab plus apatinib is one data which we have for this strategy. The second strategy was the thoracic radiotherapy, which causes the immunogenic cell death and prevents the recurrences. So this we have the match, the lead, and the biomarker. The lead trials in which in the match trial it was atezolizumab plus chemo plus low dose radiation was given, which improved the 12 months overall survival to 71%. And the durvalumab chemo followed by thoracic radiotherapy, the median progression-free survival was also improved to 8.3 months. So these are the 2 trials which have shown that you finish off your treatment with chemo plus IO followed by thoracic radiotherapy is improving your overall survival and the progression-free survival also. This is another strategy which can actually be easily implemented in Indian context because radiation therapy is something which is accessible to most of our patients. And chemo IO, if we are giving initially and if you are consolidating with radiation therapy, then yes, chances of survival are going to be improved. The third strategy was intensifying the maintenance phase. So we all know about the combination of lurbinectedin plus atezolizumab, that is the IM4 regimen, which has led to doubling of the median PFS after induction chemotherapy, chemo IO, from 5.4 months, from 2.1 to 5.4 months with a hazard ratio of 0.5, and improved the median overall survival to 13 versus 10.6 months. This 13 months is after completion of induction chemo plus IO, so 6 months of survival before with the induction chemo plus IO. So after that, we have a 13 months of median overall survival compared to 10.6 months. This is the IM4 regimen where lurbinectedin is added to maintenance atezolizumab. Then we have the durable regimen in which anlutinib plus durvalumab was added, replacing the chemotherapy with the VEGF inhibitor, improved the median overall survival to around 20.4 months. This also again after induction phase 4 cycles, they have given anlutinib which has improved the median overall survival to 20.4 months. The other one, a surprise here, is the CDK4/6 inhibitor which is used in the small cell lung cancer, trilaciclib, which was deployed prior to chemotherapy. This has led to decrease in the chemotherapy-induced myelosuppression, preserving the red cell counts, improving the compliance, and finally improving the progression-free survival. These 2 maintenance regimens were given after completion of induction chemotherapy, whereas trilaciclib is deployed prior to chemotherapy in order to decrease the chemotherapy-related toxicities and improve the tolerance to chemotherapy. The drug which we want to discuss a bit in detail today is the DLL3 inhibitor, which is the ideal precision target. It is an inhibitor of the Notch ligand, which generally drives the tumor proliferation. In a healthy cell, the DLL3 is strictly confined to the intracellular compartments, so they are not generally damaged when you have a DLL3 inhibitor. Whereas in the small cell lung cancer, DLL3 is massively overexpressed directly on the cell surface, becoming an easy target to the DLL3 inhibitor, which is the tarlatamab, which bridges the CD3 cytotoxic C cell directly to the DLL3 expressing tumor cells. So it is binding the CD3 on T cells and DLL3 on the tumor cells. This bypasses the evasion by the immune system, directly causing the cell type cytotoxicity. So for the data for the tarlatamab, we have the Delphi 304. There is a 40% reduction in the risk of death with a hazard ratio of 0.6 when tarlatamab was used in the second line setting for the extensive stage SCLC, and this was started in a step-up dosing only because being a BiTE antibody, you have the risk of ICANS and CRS, so it is a step-up dosing. And in the second line setting, it has resulted in a median overall survival of 13.6 months with adverse events of grade more than 3 around 54%. Compared to the standard chemotherapy arm, which was either topotecan or lurbinectedin or amrubicin, which has resulted in median overall survival of only 8.3 months and grade more than 3 adverse events of around 80%. The discontinuation rate with tarlatamab is also low, only 5% compared to 12% with the chemotherapy arm. So not only Delphi 304, which we have already discussed, there are other Delphi trials which are being under study or some of them have been reported. We have the Delphi 303, which was a phase 1b trial in the first line post-induction or maintenance trial. Then we have the Delphi 305 for the first line extensive stage maintenance, which is a phase 3 trial. We are also having Delphi 312, which is combination with chemo plus IO in the first line extensive stage lung cancer, and 306 in the limited stage lung cancer, similar to durvalumab post CRT. So tarlatamab is being studied in the first line in combination therapy as a maintenance therapy and also in the limited stage setting. The results are yet to be out. So the important problem with the bites is your cytokine release syndrome, which can be overcome by using the step-up protocol, starting with 1 mg on day 1, 10 mg on day 8, and then increasing it every 2 weekly afterwards, continuing it for the every 2 weekly regimen. And the rest of the precautions which we generally take for bites, like keeping the tocilizumab ready and managing the fever and hypotension as soon as a complaint, monitoring of the neurological symptoms in order to identify the ICANS, and also important is admitting the patient for the first 2 days during the first 2 cycles in order to identify early CRS and do the needful to the patient. So not only the DLL3 inhibitor, there is also expansion in the antibody drug conjugates. We have various drugs which are coming up, the IDXD, the sacituzumab govitecan. Various things are coming up in the pre-treated extensive stage or the relapse staging or in the metastatic solid tumors as a basket trials also. There are various other targets which are being coming up. One of them is the rusfertide rezetecan, which is a CD276 inhibitor. Then we have another CES6 inhibitor, the ABBV6, which is a neural tissue marker. And the sacituzumab, we all know, inhibitor of the TROP2. In the phase 2 trials, which has given a median overall survival of 13.6 months. So these are the newer modalities which we have in the relapse setting, the bites like tarlatamab, with the limiting toxicities of CRS or ICANS, which is mainly MHC independent T cell recruitment, ADCs, which directly cause cytotoxicity by the payload delivery, and we have the CAR T cell therapy also being analyzed in small cell lung cancer. Again, the similar toxicities of CRS and neurotoxicity. The logistical burden is for the complex apheresis and the manufacturing process which we come across. So this is a nutshell of the flowchart of SCLC in the 2026. Limited stage chemoradiation followed by durvalumab consolidation. And if you are planning PCI, you can have an option of avoiding it by MRI surveillance. For extensive stage, frontline, we still have the combination of IO plus platinum-based combination. And Buchan still had some anti-angiogenic agent or the CDK4/6 inhibitor. Followed by patients who are responding, you can continue with maintenance of lurbinectedin plus atezolizumab. And if there is a relapse, more than 90 days, still considered to be a platinum sensitive, still expecting that the lineage plasticity hasn't occurred. So you can do a platinum rechallenge or use other chemotherapies. Less than 90 days, platinum resistant tumors, your option A would be a tarlatamab if fit patients, or you can use other chemotherapy drugs or other clinical trials which have a targeted therapies. So there are still some unmet needs from SCLC. After the IO chemo combination, the overall survival is still plateaued at around 12 to 15 months only. No validated predictive biomarker for the SCLC to predict which patient will respond to your immunotherapy or chemo combinations. Tarlatamab cost burden, especially for our patients, it will be higher cost burden, which majority might not be affordable. So for the key takeaways, chemoimmunotherapy is the standard backbone for both limited stage and the extensive stage lung cancers. Maintenance intensification as much as possible can be done either with lurbinectedin or with radiotherapy synergy mechanism which we can use. DLL3 has emerged as a good target in the second line, might move into the first line in few days, and lot of pipeline of drugs are being studied in the SCLC setting. So from a uniform cytotoxic approach, now we have come to a tired mechanism-driven algorithm. We are shifting a disease with historical survivals of 5 years at 7% towards a long-term survival exceeding up to 20%. So this is all being possible because of the newer research which is being done to identify the subtypes and use the newer targets which can be useful in the small cell lung cancer setting. So thank you, IAIO, and thank you, Stalin sir, for this opportunity to talk on SCLC.
Yeah, thank you, Rachna. Thank you. That's a wonderful talk. You have taken us through the journey of chemotherapy, immunotherapies, and the newer targeted therapies. So, any questions you can, the participants can post in chat box, so that Rachna can answer. We'll move on to the next talk by Dr. Rajni Priya, who is a senior consultant at Mahatma Gandhi Cancer Hospital, consultant medical oncologist. So she'll be talking on the current standards in driver mutated NSCLC, optimizing the first line targeted therapy. So over to you, Dr. Rajni.
Yeah, thank you, Stalin sir. Thank you, IAIO, for the opportunity. So I think I'm not able to share the screen, sir. I should be made the host.
Will share, ma'am?
Yeah, I'll share.
Okay.
Stalin, sir? Hello?
Yes, sir.
Yes,
Is this
yes.
visible?
No, no, your screen is not visible.
Okay.
Visible, ma'am.
Yes, now it's visible.
Yeah.
Yes.
So I'll be talking on the current standards in driver mutated non-small cell lung cancer patients, optimizing outcomes with the first line therapy. So this is what we are going to cover in the next 15 to 20 minutes. So first is the scale of the problem. So every year, the global burden of the lung cancer is increasing with almost 2 million people being diagnosed with this lung cancer, with 85% of the patients being diagnosed with a non-small cell lung cancer. And approximately 1/3 of the patients have driver mutations. So if you can see the illustration, the most common mutations which we see in our practice is one minute. Sorry. Are the EGFR mutations, which is approximately 15% in US and 6, but it's more in our Asian population. It is as high as 50 to 60% of of our patients. The other common mutations are the KRAS mutations, the ALK mutations, the MET exon 14 skipping mutations, and remaining mutations are approximately 1 to 3%. I'm not able to. Are the slides moving, sir?
Yes, ma'am. Moving.
Yes, yes, moving.
Yeah.
Go ahead.
Yeah. So why targeted therapy comes first? So driver positive tumors are extremely sensitive to the targeted therapies with response rates of almost 60 to 90% compared to 20 to 30% which we get with chemotherapy alone. So if the patient has a driver mutation and if we give the targeted therapy, the median survival is as much as more than 3.5 years, with more than 7 years and above for mutations, especially like ALK. So compared to only 2.5 years when you have a driver mutation, you don't treat with the targeted therapies. Compared to 2.1 years if the patient does not have any driver mutation. So if you can see, identifying the target mutation comes first in management of these advanced non-small cell lung cancer patients. So the first thing that we do is checking for any biomarkers. So previously we used to test all our patients with IHCs, with RT-PCRs and all. But now we have NGS panels. We have comprehensive genomic profiling. We can do either broad NGS panels, and for patients who are not affordable, we are doing at least a limited NGS panel, which usually covers about 9 to 12 targets, especially for which we have a targeted therapies. So in case if you're not able to get an adequate biopsy, or the tumor is not accessible for tissue biopsy, we can even go with the liquid biopsy as well. So the main step is to do NGS, and the NGS panels which we do has both DNA and RNA. RNA based NGS testing is very important because we should not miss any fusions and MET exon 14 skipping mutations, which we usually miss when we do only DNA panels. But good thing is majority of our labs do both DNA and RNA based NGS panels. The other thing is, the other test which we do in our routine practice is a PDL1 testing. So NGS and PDL1 testing is the first way in starting treatment of our advanced non-small cell lung cancer patients. And the turnaround time, if you see, in our institute, it usually takes around like three weeks to 4 weeks. So majority of the times if the patient is symptomatic, we tend to give a first cycle of chemotherapy, and rather than waiting for the NGS reports. So, but if the patient is not very symptomatic, the disease burden is not very high, we can even wait for the NGS report and then start our treatment. So disparities in access to testing still, a majority of the low middle income countries have difficulty in testing for the targets, don't have access for the targeted therapies, and the turnaround time is also more for in majority of the centers. So where majority of tend to give with the first cycle of chemotherapy. Coming to the most common actionable or the driver mutation which we have is the EGFR mutated non-small cell lung cancer patients. So and these patients are usually females, non-smokers, adenocarcinoma histology. And 1 minute. So the standard of care for these patients for the common mutation, that is exon 19 deletion or the L858R mutations, which are the sensitive EGFR mutation, and the standard of care as of now is either osimertinib monotherapy or osimertinib plus platinum pemetrexed based chemotherapy or amivantamab plus lazertinib. So how we all started? We all know we have started with the first generation TKS like the erlotinib, geftinib, then moved to the second generation like afatinib, dacomitinib, and now we have data with the third generation like the osimertinib and the lazertinib. So previously, the median PFS with the first generation TKS are like between 9 to 11 months. 9 to 11 months compared to chemotherapy, which is just to 5 to 6 months. So now we have the third generation TK, that is osimertinib, which has shown to have an improved CNS penetration and the CNS PFS as well. So this is the present data, that is a standard of care, that is a FLAURA2, wherein we are combining osimertinib with platinum and pemetrexed. And this has been compared with osimertinib. So if you can see the median PFS, it is 25.5 months with the combination of osimertinib with chemo compared to osimertinib alone, which is 16 months. Even in patients with CNS metastasis, if you can see, it is as good as 24 months versus 13.8 months. And in patients without CNS metastasis, it is 27 months versus 21 months. So for patients who are fit with CNS metastasis who can tolerate chemotherapy, the standard of care is osimertinib plus chemotherapy. So even FLAURA2 has included patients with co-mutations like P53, which are known to have poor survival. Even this combination helps improve survival in patients with co-mutations, that is EGFR, P53 mutations as well. Coming to the overall survival, so this combination also has an improved overall survival benefit with the median overall survival with the combination is 47 months compared to osimertinib alone, which is 37 months with the hazards of 0.77. Coming to the Mariposa data, which is nothing but amivantamab. Amivantamab, we know it's a bispecific, that is EGFR and MET bispecific. This combined with lazertinib, which is a third generation EGFR TKA, this has been compared with osimertinib, which is then the standard of care. So if you can see the 12-month PFS with the amivantamab and the lazertinib combination is 73% versus 65%, and in 2 years it's 48 versus 34%. And the median PFS is with this combination is 23 months versus 16 months with the osimertinib alone. Even the extracranial PFS, you can see the median PFS is 27 months versus 18.5 months. So both are statistically significant. And this Mariposa has also overall survival benefit, and the median OS with this combination is not reached versus 36 months with the osimertinib arm. Coming to the FLAURA data, which is nothing but the osimertinib monotherapy, which is a standard, which was compared with the EGFR TKS, that is first or second generation TKS. And osimertinib has shown to have both PFS benefit and overall survival benefit. Even this FLAURA data still holds good in our practice because we see a good number of elderly patients, frail patients who may not tolerate chemotherapy combination. So still osimertinib monotherapy, which has shown to have both PFS and overall survival, is also a standard of care. So this we have already discussed. The median PFS with the osimertinib monotherapy alone is 18 months versus 10 months, and the median survival is 38 months versus 31 months. So choosing among these three options which we have in a basket, so osimertinib plus chemotherapy. So usually chemotherapies are usually given every 3 weekly once with a daily osimertinib. Amivantamab, we have availability of amivantamab, but lazertinib we don't have. Amivantamab is a costly drug which has to be given on weekly initially, followed by 2 weekly, and it comes with toxicities as well. But amivantamab plus lazertinib, if we have lazertinib available, we can consider given the good survival benefit and the PFS benefit also. So it takes into account the various things in choosing our first line therapy, that is the finances, the age of the patient, comorbids, disease burden, the responses which we need. So these are all the things which we take into account while planning our treatment. So these are the initial trials with your dacomitinib. which is also shown to have PFS and overall survival benefit as well. Coming to the EGFR uncommon and the compound mutation, so the majority of the data for these uncommon mutations come from with afatinib. So if we come across any uncommon mutations or compound mutations, we tend to go with afatinib, or we can even consider osimertinib as well. Even the amivantamab and lazertinib is also is a good option in patients with uncommon or compound mutations. Coming to the exon 20 insertions, so for this we have amivantamab plus chemotherapy, which has shown to have improved PFS. If you can see the median PFS when compared to chemotherapy alone. So majority of the times before the advent of availability of this amivantamab, we used to treat these patients with just chemotherapy alone. So if you now that we have availability of the amivantamab, combining amivantamab with chemotherapy has shown to have improved PFS of almost 11.4 months versus 6 months with hazards of 0.39%. So coming to the checkpoint inhibitors, they should not be used in EGFR mutated tumors. This is because these EGFR mutated tumors, as we all know, they have a low tumor mutation burdens and are often cold tumors where the immunotherapy agents does not act well. And they, even when you combine EGFR TKIs with checkpoint inhibitors, they increase the risk of pneumonitis as well. Coming to the EGFR resistance and second line algorithm, post progression on first line TKA, we repeat biopsy, we look for T790M mutation. If the patient has been treated on either the first or second generation TKA, we tend to switch to an osimertinib or lazertinib, T7, where these are active in the T790M mutations. So if the patient has an MET amplification, we can consider continuing osimertinib and add a MET inhibitors like tepotinib or savolitinib. If there are no actionable targets, then we go with either chemo plus amivantamab from the Mariposa 2 data. Or we have a newer ADCs also coming up like the Dato-DXd and all. So these all ADCs and the later lines of therapy will be discussed by the next speaker. Coming to the osimertinib across the disease continuum, if you can see, this is moving from advanced. First, we have the AURA data where we have in the second line, then it came to the first and the FLAURA data, and now we have the ADAURA data, the LAURA data. So this osimertinib is expanding its spectrum. It's being even used in the curative settings as well. Coming to the ALK rearranged non-small cell lung cancers. So ALK rearrangements, which are seen in 3 to 5% of the non-small cell lung cancer patients. So these are usually the patients who present to our with these ALK rearrangements are young patients who are females, non-smokers, adenocarcinoma, the signet cell histology which we have, and they are the patients who are at high risk of brain metastasis at presentation only. So previously we had the first ALK inhibitor, that is a crizotinib. It has shown to have a PFS benefit compared to chemotherapy from the profile study which we know. And post progression on crizotinib, these second generation ALK inhibitors have been tried in the later lines and shown to have PFS and CNS PFS benefit, and then move to the first line. So these are the various second and third generation ALK TKIs, that is the alectinib data which we have, which are compared with the crizotinib, that is a standard of care then. So we have the data from the GLX, LX, and for the brigatinib we have the ALTA trial, and for the ensatinib we have the EXALT-3 study, and for the lorlatinib we have the CROWN data. So all of them have been compared with the crizotinib, which is the first generation TKI, and all of them have shown to have an improved PFS benefit. So lorlatinib, which is a fourth generation ALK inhibitor. So this is a way to drug, and recently in ASCO 2026, the 7-year follow-up study has also been presented, and it has shown to have an improved PFS. Median PFS is not reached, and even a 30-month follow-up also there are no CNS events. So this is a wonderful drug, and this lorlatinib, if you can see the intracranial response rates in patients with measurable brain metastasis at presentation is almost 90%. So in case if any ALK patients present with brain metastasis is not very symptomatic, we can immediately start these ALK inhibitors with good response rates, and we can avoid even radiotherapy, which are known to have neurocognitive side effects and all. So these are the various ALK inhibitors which we have. The robust data and the go-to drug for these ALK inhibitors is a lorlatinib or alectinib, which have more CNS penetration and the CNS activity. The main problem with the lorlatinib, though it is a very good drug, is a toxicities. So the managing these patients usually have lipid abnormalities. They have neuropsychiatric issues. So that is a main issue, especially when we start in the first very 2 to 3 months. We have these cognitive effects which are very bothersome. But once the patients are used to this lorlatinib, this gives the best survival for our ALK patients. So we should not reserve our drug for the later lines. We have to give the best drug in the first go itself. Coming to the ALK resistance and sequencing after progression. So if the patients have been treated with the first generation or the second generation ALK TKS, and the patient, we do a repeat biopsy or a liquid biopsy and we find a G1202R mutation, which is sensitive to lorlatinib, we can give lorlatinib if not used in the first line. Or if the patient has already been treated on lorlatinib and progresses, then we can go for chemotherapy. So we have even novel fourth generation ALK TKs also coming up. Maybe in future we have those which act in post progression lorlatinib also. Coming to the ROS rearranged non-small cell lung cancers, we have previously all the ROS positive patients were treated with either crizotinib or the recently we had the NTRK entrectinib inhibitors available. So, but now the drug of choice for these ROS positive non-small cell lung cancers are the taletrectinib and repotrectinib. If you see, the response rates are as good as 88% and 79% respectively, with the median PFS of 45 months and 36 months respectively. So they also have good intracranial response rates as well. And these are the agents like the taletrectinib and repotrectinib are the agents which act also on resistant mutations like the G2032R, for which your crizotinib or entrectinib are not active. So we have other newer drugs like the zidesamtinib, which is also being coming up in treatment of these ROS positive lung cancer patients with good response rates. So, these are the various agents which we have in armamentarium of the management of these ROS1 positive lung cancer patients. With the median PFS, you can see with the crizotinib and entrectinib, it's just 15 months to 19 months, as compared with the novel ROS1 inhibitors, repotrectinib and the taletrectinib is as high as 35 to 45 months. So the remaining actionable mutations, that is a BRAF mutations. So now we are using for these BRAF mutations in the frontline itself, we are using these combinations like the dabrafenib and trametinib, or the encorfinib and binimetinib. So dabrafenib and trametinib, which we routinely use and available. So with the response rates of almost 64% and the median PFS of 10.9 months with an improved survival of 24 months. So this encorafenib and binimetinib has a median PFS of 30 months and overall survival of 47 months. So coming to the MET exon 14 skipping mutation, we have the capmatinib and the tepotinib. So tepotinib, we have responses of 46 to 56% with the median survival of 17 months. With capmatinib, we have response of 68% with the duration with the median PFS of 12.4 months. Coming to the RET rearrangements, now these RET rearrangements, now we have the selpercatinib available in our basket. So this has shown to have improved benefit even from the metastatic advanced setting. Now it has even moved into your adjuvant setting as well. So if you can see the data which we have from the libretto trials, so selpercatinib has shown to have improved median PFS 24 months versus 11 months, which is very high when you compare it with chemo IO combinations, which previously we used to treat. So now this selpercatinib has shown to have improved PFS with hazards of almost 0.46 and good response rates as well. So other RET inhibitor which we have is a pralsetinib. The data for the pralsetinib comes from the Accelerate trial. But now what we commonly use in our now with the availability of selpercatinib, majority of the time we go with the treatment with the selpercatinib. Coming to the previously, majority of them may used to be treated with the multikinase inhibitors like your cabozantinib, bendatinib, and alectinib. When this, especially in the later lines, when we don't have these targeted therapies like the selpercatinib available. Coming to the NTRK fusions, which is seen in less than 1% of the population. So these patients were treated with larotrectinib or entrectinib with responses of almost like 50 to 70%. And now we have a newer generation, the second generation NTRK inhibitors like the repotrectinib, which is doing really good in these NTRK fusion patients. Coming to the HER2 mutations, these patients, the drug of choice for these HER2, especially the exon 20 insertions, is zongertinib. Zongertinib, it's not available as of now, but in future, if you have these zongertinib available, it is a drug of choice in these patients. So zongertinib or the sivabertinib, it can be given alone or in combination with a TDXT. So coming to the KRAS G12C, still for KRAS G12C mutation in the first line, we are not using any targeted therapies. We have data only in the second line only. Recently, we have done a study, clinical trial being done at our hospital. LLE is a sponsor. Olomorasib is a KRAS G12C inhibitor, wherein we tried in the first line. That is not as a single agent. We tried olomorasib with chemo plus immunotherapy. So in future, these KRAS inhibitors may come into the first line, but as of now, the data for these KRAS inhibitors like the sotorasib and the adagrasib, which we have, is in the second line. Even the NRG fusions is one of the driver where first line therapy is not still a targeted therapy, and still we treat these patients with chemo plus immunotherapy as like similar to your driver negative diseases. So at progression, we have a bispecific like the sutuzumab, which is a bispecific HER2/HER3 antibody. So coming to these are the first line treatment options which we have discussed, all the targets which we have in management in the first line. So except for the KRAS and the NRG, we still go with the chemo and IO combinations. So rest of them are treated with the targeted therapies in the first line treatment only. So even in patients with the brain metastasis, so especially now that we have the third and fourth generation TKAs, especially the EGFR and ALK available, and even for the ROS, we have the repotrectinib and taletrectinib being available with good CNS penetration, good intracranial response rate. They are the drug of choice in management of these patients. So even for oligoprogressive disease patients, we know that continuing the TKA at oligoprogression with definitive therapy, especially for brain metastasis, where we can go for SRS or SBRTs, and then continuing the TKA is still the standard of care. Coming to tailoring of treatment for special population. So this we have discussed earlier, especially for EGFR patients, where osimertinib monotherapy is still the standard of care in elderly patients and with frail or poor performance or nutritional status, where still EGFR targeted therapies are the way to go, and they're well tolerable as well. And especially ALK, EGFR are seen in young female patients of reproductive age group. Ruling out pregnancy before starting this TK is very important. The newly updated recommendations, amivantamab lazertinib. This is added along with osimertinib plus chemo as a first and preferred EGFR option. Taletrectinib is a new preferred first and second line ROS1 option. And post progression on osimertinib also, now we have continuing osimertinib along with the chemotherapy. And we have new ADCs also coming up, like the datopotamab deruxtecan after osimertinib and platinum chemo progression. And for patients who have MET amplification post osimertinib progression, you can give combination of osimertinib plus MET inhibitors like tepotinib or savolitinib. And for new exon 20 insertion mutations, we have the jongertinib and the sevabertinib, usually given in combination with the TDXT. So we have a newer option for the EGFR exon insertion in the second line, that is a sunvozertinib. Still, these are not available, but in future we'll have all these newer TKAs, the third, fourth generation TKAs with good CNS activities, with good safety profile, and newer ADCs also coming up, bispecific coming up in management of these lung cancer patients. The comprehensive biomarker testing is the first non-negotiable in management of these advanced non-small cell lung cancer patients. And a careful selection of the TKIs is very important, balancing the efficacy and the toxicities. So, thank you.
Thank you, Dr. Rajni. It's a wonderful session on the choosing the best first-line treatment in the driver-mutated NSCLC. Thank you for your excellent inputs. And if there are any questions in the chat box, please answer them. Thank you once again. And for the next talk, I would like to invite Dr. Venkatesh, who is a consultant medical oncologist at Apollo Cancer Centers, Visakhapatnam. So he'll be talking on the future of targeted therapies in advanced NSCLC. So we'll see how the next generation of TKIs, ADCs, and bispecific antibodies changing the treatment landscape of advanced non-small cell lung carcinoma. Over to you, Venkatesh.
Good evening, sir. Yeah, thank you for the warm introduction and about the talk, sir. And I also thank IAO for providing this opportunity for scientific discussion today. Sir, yeah, I'm Hello.
Venkatesh, your
So
voice is
you-
not clearly audible.
Hello.
Hello?
Sir, am I audible, sir?
Yeah, now audible.
Yes.
Share your screen.
Yeah, sorry. Sorry. Yeah. Yeah. It's fine, sir. I can proceed now.
Yes,
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 sir.
you can go
Slides
ahead,
are-
go ahead,
Yeah.
go ahead.
Thank you, sir. Sorry for the technical issue. Yeah, I thank IAO team for the providing this opportunity today, and I also thank Dr. Rajni Priya madam for giving the brief overview, which has made my topic easier. So, ma'am has covered most of the target therapy part and all. So, I would briefly tell about what is ADC, what are the bispecific antibodies, and where are we, and some brief structures about ADCs and bispecific antibody, which could probably lead to the advantages and disadvantages, and where do we place ADCs and bispecific antibodies in the present scenario. Is it prior TK or with TK or after TK and all? Some brief things we will be discussing in brief. So this is a brief agenda where I'll be discussing some epidemiology and driver landscape and mechanistic foundations where the TK, ADCs and bispecific antibodies and clinical evidence we have and resistant mechanisms for all the modalities and CNS disease sequencing and future directions. So at least in this, the clinical driver part, most of the things have been covered by Dr. Rajni in the previous talk. So I'll be discussing in brief, but I'll covering them, but we'll be mostly discussing what next in the present scenario. So yeah, 85% of lung cancer non-small cell and 50% of non-small cell, non-squamous NSCLC harbors driver actionable driver mutations with the 3-year OS of first line EGFR TK monotherapy is 3-year median OS and less than 20% real world 5-year survival with EGFR TK. So lung cancer still remains the leading cause of morbidity worldwide. And yes, EGFR varying from 15 to 50%, and KRAS being 10 to 31%, and all fusions 2 to 5, ROS1 1 to 2, exon skipping mutations 2 to 3%, and HER2 about being 2 to 3, BRAF mutations 1 to 2%, and energy fusions and NTRK being about 1%. These are the prevalence of actionable driver mutations. And yes, testing is mandatory as per the finances feasibility. The better the panel, but minimum basic mandatory 9 to 12 gene panel with PDL1 is at least what most of us are doing. At least I can say. So yes, we have moved from conventional chemotherapy era to precision oncology. So where we are right now with TKS, ADCs, and bispecific era. So what exactly is the TK mechanism and generation? So TKs basically are small molecules blocking kinase catalytic activity, mostly intracellular. And we know we have first generation erlotinib, gefitinib, followed by afatinib, then third generation osimertinib, and now even lazertinib. So advanced generations have come in EGFR also. And the advantage of TK, they are oral, small size, and oral bioavailability. And lazertinib, third generation TK with high CNS penetrance, it is approved in combination with amivantamab. I will be discussing amivantamab, which is, and we all know crizotinib, lorlatinib, which is a latest third generation, and doing well with excellent ground data and all. So this is a brief structure of TK versus ADCs, antibody drug conjugate and bispecific. So if you see TK, they are intracellular small molecule inhibitors which are blocking signaling pathway of target receptors and reduce proliferation and increase apoptosis. Administration, high specificity and excellent CNS penetration varies by agent, but as the generation increases, it is excellent. But resistance via mutations or other bypass pathways. Well, antibody drug conjugates, which deliver a cytotoxic payload and target the expressing cells via internalization and intracellular release. So these mostly act on extracellular pathway by antigen binding, then receptor-mediated internalization, followed by lysosomal trafficking and linker cleavage. And the most important is the payload release into the cell, which causes DNA damage, mitotic arrest, and cell death. But key features of these are IV administration with payload-driven cytotoxicity and bystander effect, which I'll be discussing. What is the toxicities? ILD, pneumonitis, cytopenias, and GI toxicities. These are the worrisome side effects with the ADCs which we have. Coming to bispecifics, it's a dual targeting blocks multiple pathways and engages immune effector cells. Like if you see the amivantamab, which you know most commonly, it targets EGFR, target 1, and other is MET. So by targeting both, it reduces the proliferation and survival of the cells, leading to apoptosis and cell death of the cell. So, but issues are here: IV administration, dual blockade, but main toxicities are infusion reactions are the more worrisome with this bispecific antibodies. Yeah, these are the drugs which you have seen, and yeah, already discussed, almost all are in the first line setup setting only, like Metaxon, RET, ROS, and BRAF, which have already been discussed with the data. But KRAS and HER2 like Jongatinib and Cevabritinib, which is recently approved, are mostly the second line settings alongside with the TDXD. These are the things we see in HER2 mutations, and KRAS, Sotorasib, and Adagrasib are mostly the second line settings. But we are having many studies now happening in the first line with immunotherapy, KRAS inhibitors, so which are probably a future. What are the various resistance mechanisms? They are TK. They could be on target and off target. So these are the targets which we need to go for the future, developing a newer molecules where we can improve further survival. So like if you see here T790M, which is a common on-target mutation with first and second generation TKs, and post osimertinib we see most commonly C797S, and other mutations like even in ALK also G1202R, which is the second generation resistance we do see. These are all on-target mutations. But if you see off-target, MET amplifications, HER2, HER3 amplifications, oncogenic fusions, cell cycle gene alterations, or transformation, we see about 5% or something like that. Transformation is also one more thing. So on target and off target are very important things which pace our research into the further research and targeting various other pathways which with a better target agents and better survival and better drugs which could improve the outcomes of the patient. So resistance are frequently polyclonal, and up to 50% patients progressing on osimertinib unfortunately don't have any identified mechanism. So at every progression, ideally that's why we say to repeat an NGS and see if there are any other targetable resistant patterns or targetable mutations do come. That's very important in any driver mutation or any lung cancer patients on progression. So this is the so on progression of TKS, when intracellular blockade fails, TA. So the precision medicine, modern oncology has shifted to extracellular targeting with the help of ADCs and bispecific antibodies. So ADCs, as I already said, monoclonal antibody, it's a 3-component and receptor-mediated endocytosis and endolysosomal trafficking, which leads to apoptosis of the cells. And non-cleavable TDM1 needs a full antibody degradation. That's fine. But the payloads are important here, which are responsible for cytotoxicities and all. So if you see topoisomerase 1, DXD, or microtubule disruptors like MMAE or methansinoid, these are the various payloads which we see. And trastuzumab deruxtecan achieves higher of approximately 8, but this is all as the drugs are molecule varies from various drugs to various payloads and various drugs it does, and it contributes to the potency of the drug. So if you see here, various payloads have their responsible toxicities and their various mainly whatever we see is with ADCs, the ILDs and pneumonitis are more worrisome things which we do see with that. And if you see here, it is a monoclonal antibody. If you see the surface here, which is having a monoclonal antibody, and the linker, and also the cytotoxic payload here, which are important, which causes DNA damage or microtubule disrupting agents. And coming to pharmacocytosis, yes, endocytosis, then lysosomal cleavage, then apoptosis by delivering the payload. But here the bystander effect, which is a membrane permeable payload, which is a membrane permeable payload, diffuse out of dying cell to obliterate the neighboring antigen negative tumor cells. So if you see here, ADCs, they have that antigen, but if you see here, they obliterate it to antigen negative cells, which is a so I'll just give you one example here. There are two mechanisms, two types, like robust bystander or minimal bystander, where TDXD, which is efficacious in heterogeneous or low-level antigen expression, where payload diffuses into neighboring antigen negative cells. But if you see in TDM1, which is a non-cleavable linker, which has membrane impermeable, minimal neighbor killing cell killing, and may limit efficacy in antigen heterogeneous tumors. So there is a difference between various payloads also. So that is important, and accordingly the toxicities and all two. Yes, as already said, as based on the cleavable linkers or non-cleavable linkers, the toxicities varies. So if you see cleavable linkers like TDXD and all, they are enriched for pulmonary toxicities and infections, which are high toxicities and can reach extreme also. If you see non-cleavable linkers like TDM1 and all, compared to TDX, toxicities are less and dominated by ocular toxicities, where renal epithelium and stromal injury is most commonly seen. Of course, in TDM, we don't see such things, with the both the linker and non-cleavable and non-cleavable linkers. And if you see the ADC toxicity, is rates 7%, and all value TDXT specifically is about 14%, and incidence is high in NSCLC, which is highest of all solid cancers, about 22%. So this is one more concern with the ADCs, maybe the DXD and the lung cancer patients, so which is reason. And coming about the ADCs and coming to bispecific, which are engineered immunoglobulins of two distinct epitopes or antigens simultaneously. So it blocks inhibiting RAS, MAPK pathway, and PA and AKT signaling. Like if you see amivantamab, which is fully human, EGFR and MET signal, it targets both, induces receptor internalization, lysosomal degradation. So this is the same. It is EGFR and MET blocking. IV administration. Main issues concerned with this are infusion-related toxicities and dermatologic toxicities, which are EGFR-driven, and MET-driven are because of peripheral edema. So these are the toxicities which we do see with this. In brief, yes, TKS is IV, which are large, and bispecific are large, and CNS penetration is excellent with TKS, while limited with ADCs and bispecific. Of course, we do say deruxtecan and all do have, and bystander effect is very high in disease and in bispecific antibodies. The toxicity is important. GA toxicities are more in TK, while ADCs, ILD pneumonitis, and bispecifics have infusion and dermatological reactions. Yes, the FLORA and FLORA2 data where combination with osimertinib versus chemotherapy with chemo.
Venkatesa, you're not audible.
Yeah, I think suddenly it got. Now it's visible, right? Screen. Hello.
Yes, sir.
Screen is visible, right?
Yes, yes,
Yeah,
sir.
screen is visible. Yeah. So coming to ALK, we have seen first generation alectinib, crizotinib. Now we have moved to Crown data, lorlatinib, which has we recently got an excellent data where PFS is 60 versus 8%. This is the 5-year data, but we do have even the more advanced data also, recent activity, and it has a good CNS activity penetration. Sotorasib and adagrasib, these are the next generation where they have patient on failed on first line of therapy, Codebreak Crystal, and where they have compared with the chemotherapy drugs, which have shown a benefit. And MET and HER2. So if you see, these are the other drugs. Vision, tepotinib, and treatment naive, 57.3% overall response rate, and geometry capmatinib also, if you see, 68% in a previously treated, while treatment naive 44%, and lung one, jongatinib, which is a HER2 or 3, which is a target therapy, which is usually the second line, we can say. Overall response rates of 71%, and there are no ILDs in this. This is a oral drug. And metaxon 4 with coagulation, this is a mutation mechanism, resistance mechanism, which we do see. Yeah, fine. Yeah, this is the TDXT Destiny trials, which we see Destiny, they have tried with various doses, but if you see here 5.4 mg per kg dose with oral response rates of 50%, but if you see ILDs, which are about only 15%, but if you see 6.4 mg per kg dose, oral response rates are 55, but toxicities are more, ILDs are about 26%. So with the Destiny, one has an overall survival of 17.8 months and PFS of 8.2 months. But main concern is toxicities, so 5.4 mg per kg is the FDA approval, which is fine. And this is the TROP2 ADCs, datopotamab deruxtecan. If you see, there is a Tropion Lung-1 study, which has been, which has shown a median datopotamab deruxtecan median PFS of 4.4 months compared to docetaxel, and median OS is about 12.9 months versus 11.8 months with docetaxel. But grade 3 toxicities, if you see here, datopotamab deruxtecan, not much compared to the chemotherapy, if you see, but ILDs are 8.8% versus only 4% with the docetaxel. So overall, it is promising drug in the later lines, ADCs. This one more ADC, MET ADC, target MET, Luminosity trial, which is telisotuzumab vedotin, which has overall response rates of 34.6 in CMET and higher EGFR wild type NSCLC, and 5.5 months median PFS, and the median OS of 14.6 months, and it has received its FDA approval in MET-directed ADC in NSCLCs. ADC resistance. So we have seen earlier TK resistance mechanisms, but what are the ADC resistance mechanisms? So target antigen loss or down regulation, like HER2 in DAISY and TROP2 trials in preclinical models have shown, or impaired endosomal lysosomal trafficking, or ABC efflux transporter upregulation. So payload specific resistance like topoisomerase 1 alterations or tubulin dynamics, or reduced immunogenic cell death, or altered tumor microenvironment. So these could be overcome by alternate payload or bispecific ADCs or immunotherapy combinations, which are the next future. So these are the various ADC resistance mechanisms which could be targeted by overcoming either by changing the alternate payload or bispecific ADCs. These are one more things, and immunotherapy combinations. These are the various things which can be tried. So we have seen about ADCs and TKs. Then what's new or what's the data about bispecific antibodies? Yes, these are the various trials, and most common bispecific which we do know, amivantamab, which prior landmark trials, Chrysalis, where amivantamab is seen alone, exon 20 post chemotherapy, and Papillon, amivantamab with chemotherapy, which has a PFS of 11.4 months, and PFS of 11.4 months, and Mariposa is amivantamab with resertinib. Resertinib comparator with 51%. So we are using if exon so far amivantamab with chemo in exon EGFR exon 20 in a first line, but we do have Mariposa trial amivantamab with lazertinib in first line, also compared with osimertinib. So this could be the future in combination TKS and bispecifics. And post osimertinib second line is Mariposa 2, where amivantamab with chemotherapy, PFS 6.3 months and overall response rates of 64%, and intracranial PFS is 12.5 months. And amivantamab lazertinib plus chemo, where PFS of 8.3 and overall response rates of 63%. Chemo alone 4.2 months. So if you see, but toxicities are more, and with the serious toxicities being 52% versus 32%. So amivantamab with doublet chemo preferred with similar efficacy and lower toxicities. This is the final conclusion by this trial. Yes, this is energy fusion, which occurs about less than 1%, like 0.2 to 0.5% solid tumors, which drives HER2 and HER3 heterodimerization. And zenocutuzumab blocks NRG1 mediated this HER2 HER3 dimerization and downstream signaling. So this is one trial where we see it's a phase 2 where we see overall responses of 29% and 28% in previously treated, and duration of response being 12.7 months and PFS being 7 months. Adverse events predominantly being diarrhea, fatigue, nausea, and few infusion-related reactions. And it has received its FDA approval after prior systemic therapy. So please remember, these are all on post-progressions. And in development, other bispecifics are PD1 with VEGFR combination, PD1 with CTLA4, EGFR MET, EGFR HER3, and ALK and MET. These are the various bispecific constructs in development. So what is the resistance mechanism we could see with bispecifics? Again, antigen escape and T cell exhaustion and immunosuppressive TMEs like Tregs, inhibitory cytokines, and amivantamab, which has pathway alterations analogous to TK resistance, though the data is very limited, we can say. And emerging fixes how to cope up with this, like immunomodulators, proteasome inhibitors, and sequential antigen targeting. These are the things which are being researched. CNS, as this was already discussed, the CNS penetration and all. And there is one more, patritumab deruxtecan, which is active in brain mets, and datopotamab deruxtecan intracranial is about 22%, and TDXD is active in HER2 mutants. And alectinib and lorlatinib, we do see it has a good CNS penetration also. So how to sequence? First line positioning. TKI remains the preferred first line for most of the actionable driver mutations, except KRAS and HER2 and all. HER2 mutant first line, TDXD now challenged by zongertinib. KRAS, a notable exception to frontline TKS, where trials are undergoing in combinations. And lazertinib and amivantamab combination validates upfront TKI plus bispecific. And osimertinib plus datopotamab deruxtecan and osimertinib plus telizumab vedotin are under study in EGFR mutant cases, and feel like shifting from TKI monotherapy to combinations like TPA, triplet regimens are also being tried in future. So post-TKI progressions, ADCs bypass intracellular resistance signal via payload-mediated toxicity, cytotoxicity, and bispecifics block dual extracellular receptors. And so amivantamab combination overcome the EGFR MET or unknown resistance, and datopotamab deruxtecan is efficacious post-osimertinib maintenance, osimertinib in EGFR mutant NSCLC. So obtain biomarker testing at progression, either tissue or ctDNA in parallel. And TKI re-challenge remains viable, guided by ctDNA molecular response. Biomarker guided selection, as I already said, has to be done at any point. Repeat biopsy has to be done, and also to be tested for various mutations and various things in progression also. Yeah, this is the same, the toxicities of various drugs, amivantamab skin toxicities. So where do we biospecifics fit today? Preferred exon 20, yes. Energy fusion positive, no TK has activity till date, so their bispecifics have a role. And post osimertinib resistance, bispecifics have a role. And it complements TK in first line classic EGFR mutations and metaxon 4 skipping mutations where investigational bispecifics only, not are approved yet so far. But TK remains preferred for non-EGFR drivers. No specific bispecifics for other combinations apart from EGFR. And patient unable to tolerate IV infusion or high risk of VTE risk. So lazertinib and amivantamab, where lazertinib has a high VTE risk, so that has to be thought of. Future direction, reduce administration burden. So subcutaneous amivantamab is coming. Improve CNS penetration. Validate predictive biomarkers. And engineered tri-specific antibodies, CT-guided DNA adaptive therapy, and definitive standalone bispecific value where randomized trials are monotherapy versus TK monotherapy are needed in various first-line settings also. So these are the other things where next wave ADC against TROP2, HER2, HER3 with various combinations, tri-specific, where TK with bispecific antibodies are being already approved and we have the data. And NGS and ctDNA profiling at first sign of progression is optimal for further therapies. Immunotherapy in oncogen driving combinations are coming. Next generation targets like LAG3, TIM3, TIGIT, these all are coming as with combinations also with the various TKS or various other drugs. But so far still the first line, if non-oncogen driver, has to go for TK or that chemo or some other drugs. But immunotherapy in first line is not yet recommended except in the trial settings for now. Yes, this is the same again. And yeah, I thank IAO team again for providing this opportunity. And
Yeah, thank you, Venkatesh. Thank you for that wonderful lecture on the next generation targeted therapies. Now we move on to the panel discussion on immunotherapy. So, who is the ideal candidate and where we will choose this immunotherapy? And this panel discussion will be moderated by Dr. Animesh Agarwal, who is a senior consultant at Apollo Medics Super Specialty Hospital, Lucknow. The panel discussion will be on choosing the best immunotherapy strategy in advanced NSCLC, who, what, and when. So he will be introducing his panelists. So I also request Venkatesh, if you have some time, please join on the panel too and give your inputs on the immunotherapy.
Sure, sir.
Over to you, Animesh.
Good evening, everyone. Just need a moment. My net connection is acting up. I'll be logging in from my laptop. I logged in from my tab. Just a moment. Yeah, it should be done. I should be. Am I visible now?
Yes, sir. Visible.
Perfect. Right. So, thank you for the kind introduction. And we have already had some wonderful talks of talking about lung cancer, a lot of discussion on ADCs, on the driver mutated, basically the driven tumors, so to speak. And we will now talk about the tumors where we do not have any drivers, where we are going to use immunotherapy plus minus chemo, because that is now the paradigm, isn't it? Pehle tha chemo plus minus IO, now it is immuno plus minus chemo, and that is where we are today. But obviously, it's not that straightforward. So we have a panel of medical oncologists to discuss this. I have Dr. Nivedita Sen, Dr. Savinaya, Dr. Sindhu, and Dr. Santosh with me. Dr. Santosh, I can see.
Hi, sir. Good evening, sir.
Good evening. Nice to see you again, Dr. Santosh.
Yes, sir. Thank you, sir.
Yeah. So, but I don't think I see our other panelists with us today. Dr. Venkatesh was requested.
Yes,
May
sir.
I ask? So, would you be kind enough to join us?
Yes, sir, definitely.
Great. Yeah. So let's start off. And please, anybody else who is listening in who would like to have a say in the matter, please feel free to chime in. These are far from settled questions. There is no right or wrong here. We are all figuring this out as we go along. So we are essentially talking about non-oncogene addicted advanced NSCLC, and of course that means we are talking about squamous cell and adenocarcinomas, large cell. I mean, TK, that's a very small percentage of tumors. And broadly speaking, these are the data sets that we look at. The keynotes for the for pembrolizumab, the checkmates for EP, Nivo and EP, Poseidon for Durva, and tremelimumab, IMpower, and the newer checkpoint inhibitors. And we will be coming to all of them in a bit. But before we move on, just a show of hands, right? This is a simple axis, right? On this axis, on the left-hand side, we have low tumor burden, and on the y-axis, low PDL1 status on the and similarly high tumor burden. So, Dr. Santosh, first you. Low P, just a simple show of hands. Single IO, doublet IO, chemo IO, or IO alone. Okay. So low PDL1, high tumor burden.
Sir, low PDL1, high tumor burden. I would prefer chemo plus IO, sir.
Okay. What about the second segment? High PDL1, high tumor burden.
Sir, high PDL1, high tumor burden. Here also I will choose only chemo plus IO, sir. Because in high tumor burden, monotherapy IO, although data is there, but still high tumor burden, I want rapid control.
Right.
So I
Right,
will prefer chemo plus IO, sir.
Fine. Absolutely. Then Dr. Venkatesh, I would invite you for the third segment. High PDL1, low tumor burden.
So high PDL1, low tumor burden. So I would go for IO alone, sir.
Right. And low PDL1, low tumor burden.
Double IO, sir.
Doublet IO. Okay. So fine. So an excellent start. Now let's move on to the numbers just briefly before we actually come to the discussion part. So I mean, of course, these are the seminal data sets that let's just blacken out the TPS more than 50 for now. So this is the original data sets that we talk about, and we know that the overall survival is improved by the addition of immunotherapy to chemo. Pembrolizumab for adenocarcinomas, median OS 22 versus 10.6 months, good looking survival curves, and for TPS less than 1, TPS 1 to 49, although for less than 1, the hazard ratio for overall survival was a bit more, is also significant. But coming to Keynote 407, we find that for TPS less than 1 subgroup, the the curves are also overlapping, and the numbers are also not very good looking. So apart from that, for PDL1 positive tumors, for the ITT population in squamous cell carcinomas, pembrolizumab is doing just fine. Coming to the doublet IO, we have data from Checkmate 9LA and 227. So Checkmate 9LA, of course, had 2 cycles of chemotherapy. In the ITT population, again, we find good benefit, good looking survival curves, long-term data, 16 versus 11 months. Hazard ratio 0.7. For PDL1 negative, here is where the story is really impressive. So 18 versus 10 months, hazard ratio 0.6, extremely good looking survival curves. These are not the kind, definitely Keynote is struggling to match these numbers. And of course, for PDL1 positive tumors, we have some benefit. What about 227? Similar story for PDL1 positive tumors. Again, benefit is there. Remember in Checkmate 227, in the Nivo EP arm, there was no chemo, and whether it had a part A and a part B, more than 1 PDL1, less than 1 PDL1. In both arms, EP Nivo arm did not get any chemo. In PDL1 negative tumors, Nivo got chemo. Very complex trial design. It took me a lot of time to understand this trial to begin with. Anyway, so the point is that the doublet IO does seem to work regardless of PDL1 expression. Similarly, Poseidon, doublet IO in the ITT population, definitely the Durva-Tremi combination works, hazard ratio 0.76. And when we split it down to PDL1 TC, here the story becomes somewhat different. We find that in Poseidon, the PDL1 TC less than 1% does not seem to provide as much benefit. The hazard ratio is also not that good looking. In fact, in PDL1 TC less than percent, Durva has a very poor hazard ratio 0.98. At least the doublet has a 0.81, but the 95% CI is crossing 1. So for TDL1 less than 1%, Poseidon does not seem to be offering much benefit. But obviously for positive tumors, the benefit is there. Then we have, I would say, the forgotten data. I don't think we like to use ABCP very much in the first line, but we should remember that it is an effective regimen. And the ABCP versus BCP combination quite clearly does have a survival benefit, although the magnitude is not that great, hazard ratio of 0.8. But again, this regimen also struggles in TC or IC less than 1%, and does well when the tumors are expressing some PDL1 at least. Then, of course, there is the KEAP1 and STK11 story. We are all familiar with it by now. We know that the presence of certain mutations portends a poorer prognosis. This is some very nice work that was published in the Nature portfolio of papers. And over 8,000 patients analyzed, KEAP1 and STK11 mutations found, and shown that patients who have STK11 or KEAP1 mutations do not do well overall. And when on pembrolizumab, so the patients obviously they're not doing well. But when they're receiving doublet IO, Durva with tremelimumab, so that is the light blue line in terms of PFS and OS, these patients do seem to be doing better when we are using doublet IO. So this is a summary numbers of all of the data that we just saw. We can go back as and when we want. So Dr. Santosh, question, is there a best regimen one by one as per PDL1 positivity?
Sir, I think there is no hidden data. You can, although cross-trial comparison not allowed, still I don't think there is no best regimen at all.
Okay, so no, I mean say one by one. I am saying specifically PDL1 positivity के हिसाब से, as in, so a patient with low PDL1, intermediate PDL1, high PDL1.
Yes, sir.
Would you
If
say there is a best regimen for each group?
Sir, if PDL1 positive, then monotherapy can be choice.
Okay.
PDL1 low, tumor burden also low, then we can go for checkmate 9LA. But
Right.
if tumor burden high but PDL1 low, we can go like chemo plus immuno, like that only, sir.
Right. So depending on PDL1 positivity, you do have certain preferences.
Yes, sir.
Okay. So at least in the clinic, you do have, at least in your own mind, and let's just dispense with cross-trial comparisons not allowed. I mean, that is all we can really do, right? So let's
Yes, sir.
let's just keep that disclaimer aside. Fine. So
Yes,
Dr.
sir.
Venkatesh, as per histology, do you think there is a best regimen?
I think so. Just the chemo backbone do change. That's all. Otherwise, I don't think so. Of course, chemo backbone. If it is squamous, we go for taxane and carbo. Otherwise, PEMI and carbo. And with IO based on our whatever we feel on that day.
Okay.
But
So
yes, I
devil
go
that.
by more than PDL1 as a previous solution. I go more by the patient burden and comorbidities, the disease burden and comorbidities. Of course, we do have
Right.
PDL1, irrespective of PDL1, we have a data. So more than PDL1, I put more into tumor burden and tumor patient symptoms are my main concern while selecting a therapy.
Right. Okay. But then devil's advocate that in certain trials we find ki patients with squamous cell carcinoma not doing well, right? So patients with certain PDL1 expression not doing well. Okay, fine. We'll come to all of that. Okay. So Dr. Santosh, mutational profile. I think this was fairly much simpler. Tumor
Yes, sir.
mutational profile.
Yes, sir. Definitely. Some mutation like STK11, KEAP1, they're not responding to immunotherapy very well, actually. So in that case, we
Right.
can prepare immuno plus chemo or specifically only chemo.
Right. So, I mean, actually, there's enough data telling us that this monotherapy, immunotherapy at least, so Nivo alone or Pembro alone, the regimen will not help much. And in fact, the Triton trial is accruing specifically patients with KEAP1 and STK11 to receive a dual IO versus a IO monotherapy to see whether there is a benefit to adding the CTLA4. Sites of metastasis. What's your take there, Dr. Venkatesh?
Yes, sir. Mainly we do have some data where they say if more liver mets and all, some edzo doing well. So these all are post-hoc
Right.
subgroup analysis and all. But yes,
Right.
in those things, it always on individual perspective and experience. We do go by those. But yes, that's the main. That's what I see there where they highlight edzo doing well with liver mets and all. This is what I could see mostly.
Right. So, for instance, would you say that a patient has more visceral burden, more say has a more, has a much heavier CNS disease burden? Would you like to go for a IO plus PD1 plus CTLA4, or just PD1 plus chemo is enough? So, what like how would you choose?
Uh, no specific, nothing like that, sir. So based, I go by not exactly based on. I mean,
Okay.
most of our regimens,
Okay.
I mean, chemo will be my main, and with also IO, yes, definitely, sir.
Right. At least some of the subgroup data does seem to suggest that in patients with CNS disease, the Nivo-IP combination does seem to be doing a little better. I mean, I guess for lack of the number of slides available, I mean, given the time, I haven't put out the data here, but possibly we can think about it. But then I will go a little more into the histology based analysis, because I think you just mentioned, right, that histology is not one of the key criteria to think about. But again, so Keynote 407, of course, for SCCs, but we find that in Keynote 407, that is for squamous cell carcinomas, OS in PDL1 non-expressing tumors, that is TPS less than 1%, there does not seem to be a statistically significant benefit. The hazard ratio may be 0.8. The median may look nice, so 15 versus 11. But we can see the curves are quite overlapping and crisscrossing all the way till the 5 year time point. And in fact, the 5 year survival is 11 versus 13% in PDL1 negative tumors for squamous cell carcinomas. Whereas when we look at Checkmate 9LA, in those patients with squamous tumors, patients have a much better survival, and even in PDL1 negative tumors, they tend to do quite well. Yes. My slide seems to be missing. So in Checkmate 9LA, we do have subgroup analysis for patients who received patients who had squamous cell carcinomas and had PDL1 non-expressing tumors, and they did quite well. So I mean, at least that is a subgroup. I believe Dr. Santosh, or was it you, Dr. Venkatesh, who else? I think you only mentioned that for PDL low tumor burden but low PDL1, you may end up going for the dual IO PD1
Yes.
plus CTLA4.
Yes, sir.
Right. Right. So yeah. So essentially, that is you only yourself said. Yeah.
Yeah,
The
it's me.
doublet IO.
I only said. I
Yeah.
prefer double IO combination in the low PDL1. That's what I said.
Right. So that is actually being borne out by the data. So I think you're doing it more on a spinal level than on a more conscious level. Right. Uh, Poseidon, of course, the data for squamous is not that impressive. Again, as was the case for PDL1 negative tumors. So we can see that even in Poseidon, in doublet, median overall survival is really poor. And compared to chemo, the median is in fact nearly identical. Hazard ratio is just 0.85, and even the curves themselves do not look anything to write home about. So this is an opposing signal, I guess. Does doublet IO work or not? Is it just a drug specific thing? But then we come to the newer checkpoint inhibitors, right? So we have the data from Astrum for serplulimab, median survival of 23 versus 18 months, and the PFS is also improved. We do not have the subgroup data for overall survival. Then we have the data from Rationale 307, that is for tislelizumab, uh, one arm with carboplatin paclitaxel, another with nab paclitaxel, and of course the control arm with no immunotherapy. Again, both arms look fairly impressive. Median survival is improved, 23 versus 20 months, not reached versus 20 months. Hazard ratios looking decent. And then, of course, we have the Harmony 6 data, pretty much the only trial that I can think of, phase 3, a large phase 3 trial, 530 odd patients, 1:1 randomization. patient receiving of course, ivonescimab is after all a Dubai specific, but still, to own the only trial pretty much ivonescimab versus tislelizumab, chemo IO versus chemo IO, and this is the overall survival. I mean, the curves speak for themselves. The numbers speak for themselves. 28 versus 24 months, hazard ratio of 0.66. And quite frankly, the hazard ratio look and the overall survival of 28 months in all comers is a very good number, right? So this is the data that we have for patients with squamous cell carcinoma. So Dr. Santosh, based on the data that you just saw, assuming that you have access to all of these drugs, patients with squamous cell carcinoma, let's say all other things being equal, which regimen do you go for?
Sir, I will prefer Checkmate 9LA over Harmony 6. Although Harmony
Okay.
6 is having better median OS as well as other is also good, but I am experienced on double IO with a toxicity profile. So I would like to prefer Checkmate 9LO.
So pushback. What about ABCP? I mean, ABCP is not. We do have some experience with ABCP in
Yes, sir.
adenocarcinomas,
Yes, sir. But in
and
squamous,
yeah, but right, fair. But what I meant was that Harmony 6 is the data set for squamous cell carcinomas, right?
yes,
And
sir.
the hemorrhage percentage of patients having grade 3 hemorrhage events is barely 2 or 3%, if I remember correctly, in Harmony 6. So that is actually the surprising part, that patients with squamous cell carcinomas, a bispecific with a VEGF component, provides a survival benefit without any major significant increase in grade 3 hemorrhage bleeding events. So, Dr. Venkatesh, would you be tempted to use ivonescimab here?
Yes, sir, definitely. Yes, definitely, sir. I would, because the data is tempting, as you rightly said, compared to others. But for the present, because of the, I think it is yet to, we are yet to get probably that molecule, I think. Sir.
Yeah, of course. Yet to get the molecule is the biggest problem, but I found that data so fascinating
True,
that
true.
I had to discuss it.
And
But
it's
fine. So,
study is
yeah,
also
please go
quite
on.
good number comparatively. It's not a simple small study. It's actually a good
Yeah.
number of patients are enrolled.
Yeah, I mean, it's very clean trial design. 1:1, ivonescimab versus tislelizumab.
Yes,
But
yes.
then, if we are talking tislelizumab, now there are two trials, both Rationale and Harmony, where the median OS for these patients is in the vicinity of 23 months, right? While and so is the case with serplulimab and Keynote, Checkmate, Poseidon. They are all floundering.
Yeah.
So, are you what is your decision in the clinic today? Are you tempted to use Astrum or Rationale? Those are drugs we do have access to.
Yes, I have used Serplu and Tisli already in squamous in lung already. And yes, others I have used Keynote and Checkmate also. If you ask me on a day, yes, sometime most of the time finance do matter. But as with this data, yes, there's no more than think about rather than finance. Now we should think more of the data what we are seeing right in front of our eyes. Yes,
Right.
definitely I would even think of this more
So we are
frequently.
thinking of this, but I think the question to answer, Dr. Santosh, is are you going to prescribe it to a patient who is sitting in front of you in the OPD on Monday? Sir, whatever you tell me, I will go ahead with it. Cost no bar. Will you tell them that Astrum Rationale data says that your OS is going to be greater by nearly 1 year in certain cases, and you should therefore go for serplulimab or tislelizumab, not a pembrolizumab or a nivo-ipi or a durvatremi? Would you be comfortable saying that to the patient? Dr. Santosh?
Yes, sir. Yes, sir. Hearing you, sir. Yes, sir. I will. In that case, I will theoretically will choose Harmony 6, sir.
Nah, not so easy to get away. I am saying no theory allowed. Astrum and Rationale, tislelizumab and serplulimab are both available to us in the OPD.
Yes, sir. Yes, sir. That way. Okay, sir. I have some experience with Teslizumab, sir. I have not yet to gain experience on Serpilumab, but I have experience on Teslizumab, so I will comfort with Teslizumab, sir.
Okay, so so for a patient who will say that I am willing to pay for Ipi-Nivo or for Pembro, you will offer tislelizumab?
Yes, sir. Definitely,
Okay.
sir.
Okay, fine. Show of hands, definitely. Okay, Dr. Venkatesh is more on the fence, but I will confess, I myself am on the fence. I am not sure what the right answer is, and problem is that this data is mostly from arising out of East Asia, and unfortunately, the international guidelines do not endorse these drugs as yet. So we are a bit stuck slightly, but definitely very tempted to use it, and at least it gives us the base for to use it in our population where most of the patients are not going to be affording these innovator immunotherapy molecules anyway. At least the armamentarium is there. We can use it because the data is supporting it. Whether the data, how trustworthy that data is, I guess we look at Chinese data the way the world tends to look at Indian data. I mean, I'm not sure how that goes. So I think we have talked about this. So when we go on to adenocarcinoma, we land up with the same problem, right? A lot of data with Keynote 189. And here, by the way, we can see that even in PD-L1 negative tumors, the hazard ratio, the survival numbers, the survival curves, the medians, everything looks very nice and hunky-dory. And of course, in the ITT population, in the TPS 1 to 9 population as well. So for adenocarcinomas, no problems. Uh, for adenocarcinomas, 9LA regimen seems to flounder slightly. The numbers not that impressive, but still significant, statistically significant improvement with that addition. Non-squamous, here is where the Durva-Tremi combination really comes into its own. Median survival 17 versus just 10 months for squamous. And chemo arm also doing better. Hazard ratio 0.69 and the survival curves also look good. The ABCP regimen also becomes available to us here, and we have already seen these numbers. Now come the newer molecules. Again, follow-up is required, more mature data is required, but the median OS again is looking good. So in Astrum 002, there was one arm for a bevacizumab biosimilar, HLX 002, that was group A. So let us leave that aside for a moment and focus exclusively on group B versus C, where the median OS is 27 versus 20 months. Hazard ratio is 0.66. So a good number. Over 2 years, median survival in the ITT population hazard ratio of 0.66, and the benefit is maintained across most subgroups. However, even in this trial, CPS less than 1, the hazard ratio is not very impressive. The PFS is 22, the OS is 22 versus 20 months. So we can see that patients on the control arm are actually doing very well. It's not so much that patients on the experimental arm aren't doing well. So what this suggests is that patients on the control arm did get some standard of care, which was indeed the case. Around 70% of patients did get immunotherapy in subsequent lines. This is the tislelizumab data, not that impressive. So for as far as adenocarcinomas are concerned, the median OS is nearly identical. Hazard ratio also not good looking, 95% CI, well in excess of 1. And of course, this is the toripalimab data. So that is also another choice we have, because while the choice trial itself was for all comers, mixed histology, but the subgroup data showed us that for patients with squamous histology, the curves are overlapping, the numbers are not impressive, the hazard ratio is in fact 1.09. But for patients with non-squamous histology, that is adenocarcinomas predominantly for us, median OS is a striking 28 months. Now we are starting to touch numbers that we aren't used to seeing with innovators, but fine. This is what the numbers are. Hazard ratio of 0.49 for overall survival. Now, that is a very striking number. So this is the summary data. So Dr. Santosh, look down this line. Survival with immunotherapy. All of these drugs are available to you today. Which one are you using? All other things being equal.
The data from the table or the data showing It's showing favoring towards toripalimab, and we have some experience on the toripalimab also, sir. We are using it.
Okay.
So.
Okay, so when you're using
Uh,
toripalimab, you are okay. Yeah, I mean, at least the patients do seem to be responding, right?
yes, sir. Yes,
I'm
sir.
asking. I'm asking because I personally don't have that experience, so that's why I'm asking.
Yes, sir. Yes, sir. I usually we are using in NPC plentifully, but I using it one case of long. So it's
Okay.
responding, sir. Although data is not follow-up period is very less, but she is
Okay.
responding.
Okay. Okay. Okay.
But it's
And
difficult to explain as most of the NCCN and ISMO guidelines yet to update. So counseling and consenting is very important here, sir. When we everything basing on the trial data or from basically from the China, it is really tough to counsel and consent.
right, right. And Dr. Venkatesh, so Dr. Santosh has already told hit the nail on the head. Are you
No,
comfortable, therefore, prescribing these newer immunotherapy molecules?
no, sir. Actually, in compare even in squamous or this one, still I would stick to what I have been doing since many years. I would still go for either one or two, sir, because I'm more comfortable and I have used those, and at least I would be more confident to tell the patients what we are doing. Unless we have some very long-term data with all these newer drugs. Of course, I have used the other molecules also, but that's all because of main cost constraints, which I think most of us are offering those drugs only because of cost
Of course.
constraints. I can say, but still, I will go for only keynote or checkmate for now at least for maybe couple of years more till we get some long term data for all this.
Right. At the end, that is the answer, right? The numbers. I mean, we like to say that the numbers don't lie, but we also like to say that we shouldn't do cross-trial comparisons, and we say a lot of other things. But in the end, in the OPD, what matters is what the guidelines say, and at the end, we also have to defend our practice. Sometimes we have to defend it actually, even in a court of law. So when all things are considered, yes, I personally also I find myself reaching to for one or two only. I am my personal experience with Keynote 189 is the greatest, as in terms of the number of patients that I have used this regimen for, and I also have a soft spot for that regimen. But agreed that maybe with longer follow up, maybe as these companies who have launched these drugs in India, maybe as they build up their own databases of results and start publishing those results, we can have a little more clarity on what to do. So, okay, here I think we have already talked what our thoughts are. I have kept this PDL1 high expressing tumors a complete separate segment, because first, show of hands, Dr. Santosh, immunotherapy alone or combinatorial approach?
Sir, I generally prefer IO plus chemo, sir. In PD-L1 high also. Although if very low tumor burden, then I may think of IO alone. Otherwise, I am using IO plus chemo only, sir.
And Dr. Venkatesh?
Absolutely, sir. Same. Even if it is 70% also, 80% also, I would go for combination. Unless a very elderly, frail, and all, that's a different story, as a different ballgame. But if yes, I definitely go for combination, at least for 4 cycles or some basic combination. I give chemo definitely.
Right, and I will admit that that is my approach as well. And from whatever conversations we have with our other colleagues, I think it is safe to say that most of us, our medical oncology colleagues, would also agree that we try to give a combinatorial approach wherever we feel that the patient is going to be fit and tolerating the regimen. But I did look at a lot of that data, and I find, first of all, hazard ratio wise not very different, as in key we find that the hazard ratios are in the vicinity of 0.6 to 0.7 for all of these regimens for high PDL1 expressing tumors. Secondly, we also find that these patients have a median survival of ranging typically in the vicinity of 20 months. However, the innovator drugs, again, same say the innovator drugs, we find that pembrolizumab is the one that seems to be doing the best in Keynote 024, and cemiplimab in Empower Lung 1, 26 months each. Even in Keynote 189, we find that chemo plus IO, we have a median survival of around 28 months. But in the other trials, the chemo IO is not doing as well. So I mean, it's a mixed bag, essentially. What I'm trying to say here is that the whole results thing is a very, very mixed bag. Sometimes the IO monotherapy is doing very well. Sometimes it's doing just okay. Sometimes the chemo IO combination is doing very well. And sometimes at other times it's doing just okay. Right. So there has actually there was actually a proper phase 3 superiority trial designed. Key PDL1 high expressors, and these patients were randomized to receive chemo IO or immunotherapy only. And the primary endpoints were the overall response rate, the disease control rates, and of course other secondary endpoints were the oncological outcomes. But we find that in the when the results came out, I mean, at least during the interim results, when they came out, the overall response rates, it seemed like, were definitely higher initially. So at 6 weeks, 33 versus 23%. But at 12 weeks, it came down. So over at 12 weeks, the difference became much narrower, 50% versus 47%. And the disease control rate was quite similar. At 6 weeks, it's 69 versus 63. At 12 weeks, definitely it looks higher. But when we look at the oncological results, the progression-free survival and the overall survival were nearly identical, overlapping hazard ratios, nothing impressive. And after the interim analysis, the trial was closed for futility. As in, the addition of chemo was adding the toxicity, but not adding any benefit. So this is one result. A second result, so there was this meta-analysis of 24 trials for PDL1 high expressing tumors only. Patients who were treated on either PD1 monotherapy or chemoimmunotherapy, and the numbers speak for themselves. Hazard ratio of 0.67 for progression-free survival, and hazard ratio of 0.67 for progression-free survival, and of 0.74 for overall survival. Good looking curves, separating early. They stay separated for the length of the duration of the follow-up. Stay separated well beyond 5 years as well. And the numbers in these curves are also quite significant. So nearly 2,500 patients being assessed, and even at the 5-year time point, we have nearly 200 patients in play. So the absolute numbers, 29 months versus 20 months. I mean, it should be a slam dunk, right? Hazard ratio 0.74, 0.66 to 0.82. So one side, a phase 3 study says that there is no real difference. We have a meta-analysis of trials that seems to say that there is a dramatic difference. There was another pooled analysis by the FDA. Again, the same data sets that we have been looking at for all of these years. And in this data set, however, while the PFS median was slightly better, so 9.6 versus 7.1 months, the overall survival is similar. So 21 versus 25 months numerically, but the actual hazard ratio and the 95% CI was nothing impressive. So hazard ratio of around 0.9, and the hazard ratio 95% confidence interval was crossing 1. So I guess what I am saying is that the numbers are conflicting. One meta-analysis says that there is benefit. The FDA pooled analysis says that there is no overall survival benefit. And a phase 3 trial was attempted but closed early for futility after randomizing barely 85 odd patients. So, Dr. Santosh, based on this data, would you like to change your answer?
No, sir, my answer will be same only. IO plus chemo only, sir.
IO plus chemo only. And Dr. Venkatesh, you are also happy saying कि कोई नहीं chemotherapy toxicity ले लो. I am much better. I am happier getting that initial response.
Yes, as I already said, that all depends on the burden and all. But yes, at least 2 to 3 cycles I would think of to consider if burden is high, even if it is above 50%, sir, definitely.
Right. So if the tumor burden is, so let us say tumor burden is high, PDL1 is high, checkmate 9LA, or let's say keynote 189 or 407, basically maintenance chemotherapy along with with immunotherapy, or just 2 cycles.
9LE is, I'm okay with 9LE or even 189, sir. Either ways. That's all that day's choice. That's
On the day's choice, right? I mean, so that's the problem, right? We are stuck with some data that we really cannot reconcile. Uh, Essentially, I guess so. At the end of the day, we have so much data and so much follow up of all of these trials that we are all convinced that these drugs work. There is no doubt about it. And it's only selecting based on that particular day, that particular patient, cat tumor burden, what is the PDL1, what is the histology, what is the site of metastasis, what is the patient's age, fitness, comorbidities, and that is how we end up dealing with it in the OPD. But then coming to the toxicities. So of course, there is nothing new about which toxicities we encounter. We have been dealing with these drugs for a very long time now, and these are of course the timelines of those toxicities. A lot of data about that as well. So it's the rash and the pneumonitis that tends to happen the earliest, and the GI and the endocrine toxicities, the hepatitis that tends to take on a little later in the timeline. But I mean, these are things that we have been used to dealing with. But that if this the problem, of course, when we are giving these patients the doublet, uh, Dr. Santosh, what to do when the toxicity happens? Not just it's I mean it's not straightforward. This is immunotherapy toxicity only, right?
Yes, sir. Basically, when we use the immunochemo, we certainly we have some specific side effects which are linked to chemotherapy and some specific which are linked to immunotherapy. But although there is no clear cut, but when we use the double IO, then we are landing in a lot of problems, sir. Specifically when you use the ipilimumab. That's it to
Right,
judiciously use. When you the IO plus chemo or IO plus IO or a monotherapy, you have to take so many factors into account. Only
right.
not only the tumor burden, not only the PDL1, also the comorbidity and any autoimmune disease, thyroid disease, old age, comorbidity, frailty, all these things you have to take into account when considering this IO or plus IO chemo or only chemo.
Right. So patient on doublet IO with chemo comes to you with diarrhea. Now what?
If
Infective
diarrhea,
diarrhea, chemotherapy related diarrhea, immunotherapy related CTLA4 diarrhea.
sir, there is some test to look for the immunotherapy induced diarrhea, but still we can clinically judge whether it is chemotherapy induced or immunotherapy induced diarrhea clinical also. Immunotherapy diarrhea has certain time period, but chemotherapy diarrhea is generally getting by end of 1 week, sir. And it
Right.
is again recovered by end of another 1 week. But immunotherapy diarrhea, when we stop the drug or we modify the drug if grade 3, grade 1, grade 2, simply supportive care, it is improved, sir. And it generally requires a specific collectin or something test like that to know whether it is immunotherapy induced or not.
Right. Basically, the fecal calprotectin can help us with that.
Yes, sir.
When whether this is inflammatory and all. Right.
Yes, sir.
And Dr. Venkatesh, so how do you decide? How do you decide? So how do you decide which patient needs just a treatment break, which patient goes on steroids, which patient goes on immunosuppression? How many patients have let me ask you a different way. How many patients of yours have required anything more than steroids for managing the toxicity? Steroids were not enough.
Yes, sir. Mainly in the hepatitis patients, immune-related hepatitis where liver, I required MMF and all these drugs, sir. Apart from that, one patient required biologicals in colitis, as you are mentioning, and all this. The one patient, which a couple of months ago. But apart from that, many went away. Even grade 3, grade 4, SJS 10, and all also went away with just IV methylprednisolone and steroids and neuropathy. I have seen a bad neuropathy also going away with only steroids and all. Apart from this, I couldn't see major things beyond steroid what I could remember, sir. But yes, these are the things which I could think of. And they did well. And maybe chemo with immuno, if you see the initial immuno-related side effects might be bit later, not in the so early, right from cycle 1. Of course, we do see, but comparatively, they are not from cycle 1, most of them. So there we can assess whether if it's based on the prior toxicities along with chemotherapy, or by the time likely immunotherapy side effects start, chemotherapy dose might be coming, or he might be in a maintenance phase or whatever it is. So we can assess in that way. Or if a colitis and all, get an endoscopy, biopsies and all these things.
Right. Yeah, because I always keep remembering one patient I had who had pembrolizumab pemetrexed maintenance, right? 4 cycles chemo IO, then pemetrexed pembrolizumab maintenance ongoing, developed nephritis, rising creatinine. We are used to seeing that, right? I almost assumed कि ये तो pemetrexed on toxicity only. I mean, it's very common. But of course, I had that at the back of the mind that could be due to pembrolizumab, but balance of probability probably due to pemetrexed. Gave a complete treatment break, started the patient, restarted him on pembro only, again started developing the nephritis. Turned out that the nephritis was due to the pembrolizumab, not the pemetrexed. And thankfully, he's still on pemetrexed maintenance, been 3 years, and his kidneys are doing just fine. So I mean that kind of problem, I guess it's just that we are so used to seeing these drugs in our practice by now. I guess maybe 5 years back this was a challenge, but today we are much more practiced and in dealing with these issues. One brief section about second line therapy, right? So this is a problem, quite frankly. Patients who have received immunotherapy as monotherapy, fine. I think we have a lot more options. But patients who have received chemo IO in the first line, what do you do in the second line? Dr. Santosh?
Yes, sir. If you use the chemoimmun on the first line, then it is a little bit challenging actually for second line. I generally prefer docetaxel in my most of the patients. But again, we have some targeted therapy or tumor agonist like NTRK, HOT2, data are there. Again, we can use the docetaxel plus ramucirumab. But I prefer generally docetaxel in second line.
Okay. So Dr. Venkatesh, I know, of course, अगर कुछ actionable if we get an actionable biomarker, that is the easy way out. But more often than not, we find stupid mutations, right? We will find PIK3 mutations sometimes. We will find all sorts of mutations that have no business in lung cancer, and we don't have any actionable targets. So what do you choose?
True, sir. See, this is most common scenario. Yes, I would go for a taxane based with a Ramo or chemotherapy based predominantly. And as you rightly pointed, I would like to say, sir, I have seen few prescriptions where off-label PIK3CA alpelisib being given in lung cancers. These are not off-label. We might do in the later lines when patient is exhausted with all the lines and whatever it is. But still, that's being done. No wrong, I would say. When we exhausted options and all, off-label treatment is fine. But at least second line, I would stick to chemotherapy or some target if he gets it.
Yeah. Do you think the ADCs are coming here?
Yes, probably. Yes, definitely. If ADCs now we can see bias, probably that's all depends. Yes, sir, definitely. Yes, if you get some ADCs are probably yes, having combinations of ADCs with IVOs coming, so some target combinations and all. Datopotamab, yes.
Yeah. So actually, the second line, basically post IO chemo, it's still a huge problem. At least in actionable mutations, there are multiple lines of targeted therapies, and then you still have the option of chemo IO, and then you start worrying about ab kya kare. But yeah, for patients who do not have any actionable mutations, those median survivals are really sad looking, and we still need to be doing a lot better. But at least the 5 years on a just I guess unrelated or maybe related note, the 5-year EFS data was just published for Keynote 671. Although I don't know how many resectable CL lung any of us sees in our OPDs. Dr. Santosh, how many resectable CL lungs do you see in your OPD?
Very few, sir. Out of all long cases, hardly 1 to 2%, sir, I can say.
1 to 2%.
In recent 3 to 4 months, I've seen only 2 cases, sir. In
the last 1 year?
Last 1 year, I've seen around 4 or 5, sir, maximum.
And Dr. Venkatesh?
Actually, till couple of months ago, I was in Tata for all 3 years, so I used to get to see quite a few. I can say up to 10 or below 10. I can say, sir, more or less around 10. I can say this 1 year.
Right. Because the data for the Keynote 671, the 5-year EFS, 5-year survival, I think is around 68 or 69%. So 5-year survival of 68-69% in CL lung with no driver mutations is actually a very good looking number, not a number that we are used to seeing. And I hope that we find more patients with resectable disease, because Otherwise, these patients don't really do well, and we need to be finding some way or the other to do better for these patients. I mean, I guess there is no real end to a discussion on immunotherapy. I have tried a bit to, at least answer the questions that we do try to answer in the clinic. But I guess that's it for now. We do have a wide array of choices, but yes, somehow there is still more and more emerging data, and hopefully with time we will have more drugs. Hopefully with time we will have better options, more options for these patients apart from just immunotherapy and chemotherapy. Yep. Thank you for your time, gentlemen.
Yeah, thank you, Dr. Animesh. It was a wonderful panel discussion. And thank you all panelists. So we had a wonderful discussion today on the lung cancer. So the three talks were excellent, and it was followed by an excellent panel discussion. Thank you all. Thank you all, faculty, for taking out your time in a busy schedule. Thank you all. Thank you all the speakers and panelists. And I hand over back to IAIO.
Thank you, sir. As we come to the conclusion of today's enriching session, I would like to sincerely thank our esteemed Program Director, Dr. Vala Stalin Chaudhary, for his leadership and guidance in bringing together this excellent scientific program. And our heartfelt thanks to all our distinguished faculty, speaker, moderator, and panelists. Thank you all for sharing our valuable expertise and practical insight with us. We would also like to express our sincere gratitude to all the participants who joined us today and contribute to making the session interactive and meaningful. On behalf of IAIO, thank you all once again for being a part of IAIO Expert Insight Lung Cancer. We hope you found today's scientific discussion informative and valuable for your clinical practice. Have a wonderful evening, everyone. Stay safe, and we look forward to welcome you again to our upcoming IAIO academic programs. Thank you. Good night.
Good night, everyone.